We'd like to start this first training session to recognize today's presenter, Kip Sullivan, Juris Doctor. Kip is Minnesota's local health policy expert. Also recognized nationally for his expertise and substantial contributions to health policy literature, he has been organizing for universal health insurance since 1986 and for single-payer health care since 1989, and he has written extensively about our expensive and harmful health care system. He was an original member of the Board of Physicians for a national health program, PNHP Minnesota, and of Healthcare for All Minnesota, and now serves on Healthcare for All Minnesota's Legislative Policy Committee. We turn to Kip with gratitude for training all of us who are advocates for reforming our for-profit healthcare system into a single payer where we, the people, and patients come before profit.
This is the first of 4 training sessions that will introduce you to the main issues raised by the debate about how to reduce the high cost of healthcare. We've entitled this training, Why Have Minnesota's Cost Containment Policies Failed? The answer to that question is because the legislature and Congress have been barking up the wrong tree. For 50 years, they have tried to contain costs by reducing the quantity of medical services rather than the price. Since the early 1970s, Congress and the Minnesota legislature have focused almost exclusively on the quantity factor because they were persuaded on the basis of no evidence that doctors were ordering services patients don't need, and HMOs would make them stop doing that through a combination of financial incentives to deny services and micromanagement of doctors. Those tactics, plus limitations on patients' choice of provider, which means doctor and hospital, came to be called managed care by the mid-1980s. I have included in this slide 2 sentences from an op-ed published in the Wall Street Journal in 2015. And now I see I've got everybody over here. Well, I'll try to work around everybody's photographs. The author, Drew Altman, wrote, most of today's health cost strategies aim to reduce the volume of tests, procedures, and hospital days. Very few aim at the price. Now, that's precisely what you should expect from 50 years of obsession with quantity when price was the issue that Congress and the Minnesota legislature should have been addressing. In this session, session 1, we'll review the evidence that U.S. and Minnesota costs are high, and the spread of managed care cost control tactics is the reason why. The spread of those tactics drove up administrative costs and provoked merger mania throughout the entire system. Now, I'm going to begin with a slide showing U.S. costs are high compared with other wealthy nations. And then we're going to look briefly at another slide showing that Minnesota became a very high cost state starting in the early 1990s. In this slide, you see U.S. spending on healthcare as a percent of gross domestic product, which is a proxy for national income, compared with that of 10 other wealthy nations. You see U.S. spending is described as a percent of gross domestic product. U.S. is the red line. You see that in 1980, these 11 nations were bunched up together. They spent 5 to 8% of their national income on healthcare that year. And if we could extend this graph further back, you'd see these lines coming even closer together. But something happened in the early 1980s, caused the U.S. to become an outlier. By 2019, we were spending 17% of our national income on healthcare, far more. In second place, Germany, 12%, and third place, Switzerland, 11%. This slide shows you Minnesota per capita healthcare spending as a percent of the national average over the period 1991 to 2020. This is as far back as the state level data we have goes. The data is from reports on state level healthcare spending issued every 5 years by the Office of the Actuary within the Centers for Medicare and Medicaid Services, CMS, the agency that runs Medicare, Medicaid. The Office of the Actuary releases national spending data every year, but it publishes these state level spending data reports only every 5 years. You see that Minnesota entered the 1990s as an average cost state, but something happened in the early 1990s that caused our healthcare costs to soar compared with other states. If we go back to the last slide, you can see that even at 1991, when we were still an average cost state, there's really nothing to write home about, because now we're average with by far the most expensive healthcare system on the planet. But in the early 1990s, something happened in Minnesota that drove our costs through the roof. What was that? During the period 1991 to 93, two healthcare commissions appointed by the legislature and the Minnesota legislature endorsed managed care. We'll discuss those events in more detail in session 2. If you'd been asleep in a cave the last 3 or 4 decades and I woke you up and I show you these slides, you'd be excused for thinking the US and Minnesota made no effort to cut healthcare costs. That impression would be wrong, of course. US and Minnesota policymakers actually tried to cut costs. Nothing worked. These next two slides contain statements from the Department of Health. You'll often see it described as MDH in these slides, confirming what the last 2 slides make obvious. Nothing Minnesota has done to cut costs has worked. And here's an example where I'm going to just quote a few words out of these slides. I think it's important for you to know where the document comes from, where the words come from. In this case, it's from a report from the Department of Health in 2019. And you can see that the report says for the past 2 decades, one major lesson has emerged. Healthcare spending generally grows each year and is incredibly resistant to attempts to change its trajectory. Here's a similar statement made 2 years later by Stefan Gildemeister, the chief economist at the Department of Health, and he made a very similar statement. He said over the last 20 years, I would say over the last 50 years, states have tried everything under the sun, including efforts to reduce unnecessary cesarean deliveries, diagnostic imaging, and rehospitalizations. Does that tell you? We've been concentrating on quantity, but individually or collectively, these initiatives have not fundamentally and sustainably altered the trend of excessive spending. This slide depicts the most important reason why nothing worked. It shows administrative costs in this blue-green slice turning into a mountain. And it shows that they exploded. They grew rapidly in the late 80s and exploded in the 1990s. The little yellow sliver down here is growth in the physician workforce. What this slide does not tell you is that mergers also accelerated in the 1980s and exploded in the 1990s. When any sector of the economy consolidates, prices go up, especially if that sector is experiencing soaring administrative costs. It's easier for a business to pass on rising administrative costs by raising prices if it's one of only a few sellers versus one of many. So soaring administrative costs and merger mania are a lethal combination for healthcare costs. So what caused soaring administrative costs and merger mania? Answer: endorsement of managed care by Congress and the Minnesota legislature way back here in the 1970s, as well as by large employers, and resulting in the rapid spread of managed care cost control tactics in the 1980s and early 1990s. I'll describe how that happened in the next session when we discuss how Minnesota became a high-cost state. In this session, I want to make sure you understand what managed care means and how little evidence there was to support it, and how little there is today. The phrase managed care often refers collectively to the cost containment tools pioneered by HMOs. Those tools fall into 3 categories: financial incentives to induce doctors to order fewer services, micromanagement of doctors, prior authorization being the most obvious and irritating example, and constriction limits on choice of provider, doctor, and hospital. As I noted in the introductory video, if you're concerned about spending in any sector of the economy, you have to be concerned about these 2 numbers, price and quantity. Managed care advocates claim excessive quantity is the primary problem, and they blame the fee-for-service method of paying doctors for this alleged overuse. There was a tiny kernel of truth to this claim that the fee-for-service method induces overuse. Doctors or anyone else who are paid a fee for each service they They have an incentive to produce more services. But evidence showing that doctors routinely cave into that incentive has never been published. Excessive price driven by administrative costs and merger mania is the correct diagnosis. But Congress and the Minnesota legislature bought the overuse due to service diagnosis, and they enacted legislation in the early 1970s promoting HMOs. Now I go back to our blue-green mountain for a minute, because it helps me give you a brief history of the rise of managed care ideology. And I'm calling the combination of the diagnosis and the solution ideology, because it was simply based on groupthink, faith. In 1970, a Minnesota physician named Paul Elwood invented the HMO concept, and he sold it to the Nixon administration, and shortly after that to the Democrats who controlled Congress. In 1972, Congress inserted HMOs into Medicare, and that tiny little HMO program has now metastasized into a huge, overpaid Medicare Advantage program that is wasting money and harming lots of patients. But that's where it began, with the insertion of HMOs into Medicare in 1972. In 1973, both Congress and the Minnesota legislature enacted laws to promote HMOs within the private sector. By 1985, those cost control tactics that HMOs use, limited choice, micromanagement of doctors, financial incentives, they were not spreading so far that observers needed a label to describe all of them. And the phrase managed care was invented by somebody right around here in 1985. In the late 1980s, inflation worsened, and that induced employers to start pushing their employees into HMOs, because the HMOs were keeping their premiums 5 to 10% below those of traditional insurers. And traditional insurers, seeing the threat to their market share, they either started their own HMOs or their own PPOs, preferred provider organizations. A preferred provider organization is pretty much like an HMO. In fact, the distinction between them disappeared about a quarter century ago. But the traditional definition of a PPO is you will get some of your bills paid for if you go outside of their narrow networks. Now I'm going to show you 3 slides quoting experts who said there was never any evidence for managed care. This first quote is from Uwe Reinhardt. He recently passed away. He taught for years at Princeton. And as soon as the managed care fad began to emerge, he noticed there was something wrong with it. There was no evidence for it. This is what he said in 1973: the much touted idea of a national network of presumably competitive health maintenance organizations appears to have been proffered on the basis of intuition or faith rather than on the basis of convincing evidence. My only quarrel with the statement is he shouldn't have said appears. That was based on intuition or faith. This is a similar statement from the U.S. General Accounting Office, now called the U.S. Government Accountability Office, from a report issued in, now I can't see past the photographs. They reached the same conclusion. They said that evidence for the effectiveness of managed care to control costs is inadequate and inconclusive. Do not even know managed care saves money. One last example from 2006. This is from Robert Galvin, for many years the health policy expert at General Electric. He said, we still did not know conclusively to what extent traditional managed care actually saves money for employers. So there you have it. The idea was presented without evidence, and as the decades went by, no evidence arose to suggest that the original decision was correct. Now, if there was never any evidence for managed care, how did HMOs keep their premiums below those of traditional insurers and force traditional insurers to adopt managed care tactics to become either HMOs or PPOs? Well, there are basically over the decades 4 reasons. In the early days, the HMOs had 2 advantages that the traditional insurers did not have. They enrolled healthier people, and it's just largely because sicker people didn't want to give up choice of doctor. Secondly, the HMOs didn't pay for 10 to 15% of their enrollees' services because the enrollees sought care outside the HMO network. And as the years went by, the HMOs were gathering more market share from traditional insurers using these advantages. But as they got big, they implemented another big important tactic. They used their large size to demand steep discounts from doctors, hospital suppliers, and workers. And then pretty much all along the way, they denied necessary services. And I'm under the impression that this is getting worse and worse as every insurance company in America is now into the managed care game. I want to turn now to a slide that discusses this issue. HMOs using their large size demand huge discounts from their workers and from hospitals and doctors. This is from the horse's mouth. George Halverson and George Isham wrote a book when they published it in 2003. Halverson was the CEO of Health Partners before going out to Kaiser Permanente, and Isham was Health Partners' medical director. And here's what they said. HMOs negotiated deep discounts, 30 to 50% in some cases. These discounts cut health plan costs to the point that the plans, the HMOs, could significantly underprice the old pre-HMO traditional insurance companies. The one-sided price negotiations turned providers into enemies. An even longer range problem was the deep discounts strongly encouraged providers to consolidate into larger organizations to create their own negotiations leverage so that the next time they wouldn't be rolled over by the big HMOs. But despite the lack of evidence for managed care and the growing evidence that managed care had backfired, insurance company execs continued to claim that overuse is the problem. Their HMOs and PPOs are the answer. The next 4 slides, I'm going to go through them very quickly, give you examples of insurance company ACOs whining about alleged overuse. Here's the first example. It's taken from the Star Tribune, an op-ed published in 1998. Whoops, I've got to spell his name correctly. Andy Joukowsky, then president and CEO of Blue Cross Blue Shield, and another Blue Shield employee, Stephen Foldis. And here's what they said. In the 1970s and early 1980s, medical journals were loaded with studies, and the popular press carried tales about unnecessary tests and procedures. Yes, that's true, but it was based upon a lot of groupthink and some junk science. Managed care emerged to curb health care's financial excesses. Yeah, that was the excuse they offered us. Managed care achieved cost control largely by reversing the financial incentives of fee-for-service medicine. Boy, that was nonsense in the 70s when it was first promoted. But by 1998, when Minnesota's costs were 10% above the national average and US costs were way above those of other countries, that was a laughable statement. Similar statement from William Donaldson, CEO of Aetna. Another statement from Catherine Hamilton, Vice President of Blue Cross Blue Shield of Vermont. She says, why do we need HMOs? Curb overuse. And finally, here's a statement from Francis Croson. He used to be an executive at Kaiser Permanente out in California, admonishing Massachusetts, you've really got to contain costs by getting rid of unnecessary care. Primary cause of unnecessary care is the costly brew of expensive technology and fee-for-service payment of physicians. Not a shred of evidence, they just keep saying. So to summarize session 1, US costs are far above those of other nations, and Minnesota's per capita cost is even higher than the US average. The reason for that is that Congress and Minnesota's legislature endorsed the wrong diagnosis, overuse due to fee-for-service, and the wrong solution, managed care. And managed care drove up administrative costs and provoked mergers. In short, the cure worsened the disease. Managed care means financial incentives for doctors, micromanagement of doctors, and limited choice for patients.
Thank you for watching this video. See the description below for links to the primary sources used during this training. Healthcare for All Minnesota has more videos and looks forward to you joining our efforts.